Benign neck swellings. Now first we start with the anatomy of the neck. Here we can see this is the carotid triangle. This is the sternocleidomastoid muscle, which is dividing the anterior and the posterior compartments. And the muscles, this is the trapezius muscle, this is the sternocleidomastoid muscle, this is the anterior belly of the digastric, this is the posterior belly of the digastric muscle, this is the stylohyoid muscle, this is the superior belly of the omohyoid muscle and the posterior belly. This is the hyoid bone. Now let's talk about the triangles. This is a submandibular triangle, the submental triangle, muscular triangle, carotid triangle, posterior triangle. Here you can see how sternocleidomastoid is dividing the anterior compartment with the posterior. So this forms the posterior triangle. Anteriorly there is sternocleidomastoid, posteriorly there is trapezius, inferiorly there is a clavicle. Now the classification of the neck notes according to the levels. Level 1 there are submandibular and submandibular. Level 2 there is upper jugular. Level 3 middle jugular. Level 4 lower jugular. Level 5 there is spinal accessory and transverse cervical. This area. This is spinal accessory and the transverse cervical. Level 6 is the pre-laryngeal, pre-tracheal and paratracheal. Level 7 is the nodes of the upper mediastinum. So these are nodes of the upper mediastinum. This is level 6. So here is the trachea, there is the pretracheal, paratracheal and the pre-laryngeal. And level 7, it has this level. These are nodes of the upper mediastinum, above the mediastinum. Here you can see how this is level 1, 2, 3, 4, 5, 6. Well, 1 is further divided into 1A and 1B. 2 into 2A and 2B. Then 3, 4, then 5 into 5A and 5B. Now the classification, there are various causes of the neck swellings. They can be divided into midline neck swelling and the lateral neck swellings. Well, in the midline you can see from above downwards, we can start with the Ludwig angina. Then the enlarged submental lymph nodes, the sublingual dermoid, the subhyoid bursitis, thyroglossal cyst, goiter of the thyroid isthmus and the pyramidal lobes, enlarged lymph nodes and lipoma of the suprasternal space of Burns, retrosternal goiter. Then comes with thymic swelling, dermoid cyst, bony swelling from sternum. Now swelling of the skin and the superficial fascia, these are the sebaceous cyst, lipoma, fibroma and neurofibroma. The lateral swellings are the swellings in the submandibular or the digastric triangle. So these are the enlarged swellings in the submandibular digastric triangle. So what can be there? There can be enlarged lymph nodes, enlargement of the submandibular salivary glands, plunging ranula, extension of the growth from the jaw. Swelling in the carotid triangle, these are the branchial cysts, aneurysm of the carotid artery and the carotid body tumor. Bronchogenic carcinoma, thyroid swelling, sternocleidomastoid tumor of the newborn baby and Laryngocele. In the posterior triangle, there are the enlarged supraclavicular lymph nodes, cystic hygroma, the pharyngeal pouch, cold abscess, lipoma. Subclavian aneurysm, cervical rib, sebaceous cyst, lipoma, hemangioma, neurofibroma. Again we review it. In the midline swelling, they are from above downwards. There is a Ludwig angina, there is enlargement of the submental lymph nodes, sublingual dermoid, subhyoid bursitis, thyroglossal cyst, goiter of the thyroid isthmus and the pyramidal lobe, enlarged lymph nodes and lipoma in the suprasternal space of Burns, retrosternal goiter. Then comes the thymic swelling, dermoid cyst, bony swellings from the sternum. The swellings of the skin of superficial fascia, these are sebaceous cyst, lipoma, fibroma and neurofibroma. In the lateral wall, because of the swellings in the submandibular or digastric triangle, there are the enlarged lymph nodes. The enlargement of the submandibular salivary glands, the plunging ranula, extension of the growth from the jaw. Swelling in the carotid triangle are the branchial cyst, aneurysm of the carotid artery, carotid body tumor. Bronchogenic carcinoma, thyroid swelling, sternocleidomastoid tumors of the newborn baby and the Laryngocele. In the posterior triangle, there is an enlarged supraclavicular lymph node, cystic hygroma, pharyngeal pouch, the cold abscess, lipoma, the subclavian aneurysm, the cervical lip, the sebaceous cyst, lipoma, hemangioma, neurofibroma. Now what is a thyroglossal cyst? This is a midline neck tumor. It is cystic swelling developed in the remnant of the thyroglossal tract. Development from the ventral portion of the endoderm between the first and second branchial arch, a diverticulum extends downward to form the median thyroid diverticulum. This diverticulum moves downward and comes in front of the thyroid cartilage to form the isthmus and pudendal lobes. This tract is known as the thyroglossal tract. Failure of the tract to involute may result in a thyroglossal cyst formation. The clinical features, the age may appear at any age, usually between the 15 to 30 years of age. Equally in both the sexes, the commonest predilection is a painless midline swelling in the neck of long duration. The pain in the cyst is a sign of an infection and systemic symptoms are never seen. Well, for the examinations, its position as per the frequency is a subhyoid position in the region of the thyroid cartilage, suprahyoid, subhyoid, suprahyoid in the region of the thyroid cartilage at the level of the cricoid cartilage in the floor of the mouth, beneath the foramen cecum. Cyst is spherical, oral, 0.5 to 5 cm in diameter, consistency is often firm to hard. Fluctuation test is positive, transmission test occasionally positive. The mobility moves on deglutition and on protrusion of the tongue. So this basically moves on deglutition and on the protrusion of tongue. Cyst can be moved sideways, not vertically. Treatment of the excision of the cyst by the cystic operation. Now comes the branchial cyst. Development is the second arch, grows ventrally as also caudally, and grows at a greater pace than the third and the fourth arches. What happened actually? The second arch grows ventrally as also the caudally, and it basically grows at a greater pace than the third and the fourth arches. The second arch gradually overlaps the third and the fourth arch at the end of the fifth week. A ridge produced by this arch grows downward and meets a smaller bridge called the pericardial ridge, may meet at the fifth arch. A small depression is formed which is superficial to the third and the fourth arch and deep to the second arch. This is called the pericervical sinus. If this sinus persists, forms the branchial cyst. Here you can see how the branchial cyst looks like. Clinical feature. Though congenital, it does not manifest before puberty. Presents as a painless swelling in the upper and the lateral part of the neck. If infected, it is painful. A recent upper respiratory tract infection is often described. Examination. Site. Swelling occupies the upper and the lateral part of the neck, deep to the upper third of the sternomastoid muscle. Protrudes from the beneath the anterior border of the sternomastoid. Usually oval in shape, between the 5-10 cm in diameter. Surface is smooth, edges are distinct, consistency may vary from firm to hard. The fluctuation test is positive and transmission test is negative. Mobility. Lump is not fully mobile as it is deep to the sternomastoid muscle. It cannot be reduced or compressed. On aspiration, the cholesterol crystals can be demonstrated in the aspirated fluid. Pathology. Usually lined by the squamous epithelium with a transitional type of pseudostratified epithelium. Its wall contains large amount of lymphoid tissue, so prone to infection. So contains some viscid, cheesy material and cholesterol crystals. Well, the treatment, if infected, then the attempts are made to aspirate the content and treat with IV antibiotics. Lateral cervical cyst should be surgically removed. Transverse increase incision is made over the cyst and the dissection is followed along the anterior border of the sternocleidomastoid. If a cyst is adherent, then the dissection should be continued as for the neck dissection with identification of the spinal accessory nerve, hypoglossal nerve and the carotid sheath. Now the sublingual dermoid cyst. It is a congenital sequestration of the dermoid cyst formed by the inclusion of the surface ectoderm at the fusion line of the first branchial arch. Such a cyst is always in the midline, maybe above or below the mylohyoid muscle. Few dermoids may be seen in the lateral variety, which usually derive from the second branchial arch. Now the clinical feature. Age. Even though the congenital patient usually present between 10 to 25 years. Both sexes are equally involved. Patient complains of painless swelling under the tongue, in the floor of the mouth or just below the point of chin. Cystic swelling and fluctuation test is positive. Transmission test is negative. Bioanal palpation reveals the extent of the cyst. Pathology. It is a thin walled cyst lined by the squamous epithelium. Wall contains hair follicles, sweat glands, sebaceous cyst in the lining epithelium. Its consistency is cheesy material. Unlike other dermoids, it never contain hair. Treatment. Total excision is the treatment of choice. Subhyoid bursal cyst. It is the enlargement of the subhyoid bursa within the accumulation of inflammatory fluid within it. The subhyoid bursa is situated below the hyoid bone and is in front of the thyrohyoid membrane. Clinical feature: the pain with a swelling just below the hyoid bone. Pain with swelling just below the hyoid bone in the midline is a characteristic. Swelling is oval in shape and moves with the deglutition as it is attached to the hyoid. Well, it does not move the protrusion of tongue. Cystic swelling, no fluctuation test positive, transformation test is negative. Well, the treatment is complete excision of cyst by making a transverse incision over the cyst. Now comes the cystic hygroma. It is a cystic swelling which contains the multiple locules of clear lymph. Development of the lymph system arises from two jugular sacs, two posterior sciatic sacs, and the single retroperitoneal sac. Endothelial outbudding from these extend centrifugally to form the peripheral lymphatic system. Probably cause of the cystic hygroma is the endothelial fibrillar membrane sprout from the walls of these cysts. Penetrate the surrounding tissue, canalize it, and produce more cysts. Pressure of the cyst forces a tumor along the lines of the least resistance into the planes or spaces between the large muscles and vessels. Clinical features: posterior triangle of the neck is the commonest site. The swelling gradually extends upward towards the ear and downwards towards the axilla. Age: it is the earliest swelling, and it is the earliest swelling one can see in the neck. It manifests in the early infancy, occasionally present at birth. Only complaint is lump or swelling. Parents bring children for disfigurement. Well, the examination: its usual position is the lower third of the neck in the posterior triangle. The size varies, usually round in shape with a smooth distinct margins. Surface is smooth and lobulated. Consistency is extremely soft and cystic. Fluctuation test is positive. Impulse on coughing if is present. Swelling is partially compressible as fluid is in one locule passing into the other. It is brilliantly translucent swelling. Here you can see this is lymphangioma. Well, the complications: sometimes growth is extremely rapid and may cause the respiratory difficulty. In such cases, the immediate aspiration of the contents is necessary. Tracheostomy may be required. Swelling may get infected as a result of the nasopharyngeal infection. Well, the treatment: the excision is treatment of choice. No operation should be conducted without the pre-operative chest CT to rule out the mediastinal involvement. Sclerostin injections and incision drainage are the worthless. Now comes the branchial fistula. It is a congenital and develops from the failure of the fusion of the second branchial arch with the fifth. It consists of skin lining tract opening internally as a slit on the anterior aspect of the tonsillar fossa. The external opening is at the anterior border of the sternocleidomastoid at the junction of the middle of the lower third. It almost always present in the young infants as a discharging sinus, which may or may not have internal fistulous communication. Those from the first arch open at the junction of the cartilages and the bony meatus. The third and fourth arch sinus have internal opening at the level of the pyriform sinus or below. Course of the branchial fistula: from opening on the skin, the fistula passes subcutaneously to the level of the upper border of the thyroid cartilage, where it pierces the deep fascia. Fistula then passes through the bifurcation of the common carotid artery, being superficial to the internal carotid and the deep to the external carotid artery. The fistula then passes deep to the posterior belly of the digastric and the stylohyoid muscle. Crosses the superficial to the internal jugular vein, hypoglossal, glossopharyngeal and stylopharyngeus muscle. Then it passes the superior constrictor muscle and opens into the posterior pillar of the fascias behind the tonsils. While the treatment is the excision of the fistulous tract, cyanogram may be made by the injection of a radio-opaque dye into the fistulous tract to know the upper limit of the fistula. An elliptical incision is made around the external opening and the dissection is continued upward through the superficial fascia and platysma up to the upper border of the thyroid cartilage. Gentle traction to the fistular tract will facilitate identification and dissection upwards. The second incision may be required above the upper border of the thyroid cartilage, transversely placed along the Langer's line. The usual part of the tract is dissected through this incision up to the pharyngeal wall. This is a step-ladder pattern of dissection of the branchial fistula. Complete removal is required to avoid the recurrence. Now the sternomastoid tumor. Known as the congenital torticollis, etiology, infarction of the central portion of the sternomastoid muscle at the time of the birth. Trauma at the time of the birth may lead to the hematoma formation, replaced by the fibrous and the tumor formation. One of the clinical features, age. This is one of the earliest swellings seen in the neck. May be noted several days to months after the birth. Main complaint is swelling. Mothers notice that a child keeps his head tilted to one side. Any attempt to turn the head straight will cause the pain. Torticollis does not become apparent before the age of 4 as it becomes obvious with the growth in the length of the neck. Well, the examination, this tumor is found in the middle third of the sternocleidomastoid. Swelling may be tender in the first few weeks of the life. Usually 1 to 2 cm in diameter, swelling is a fusiform in shape along long axis of sternomastoid muscle. Surface is usually smooth and anterior posterior margins are distinct. In the beginning, the swelling is firm but becomes harder with time. Eyes must always be examined for the squint to rule out the cause of the torticollis. Treatment: when noticed at the birth, the infant's head is gently manipulated through a full range of movement every day. This will prevent the formation of the torticollis. When condition is noted only after development of the torticollis, a brace or a harness may be used to correct the torticollis. Daily physiotherapy is essential. It is not successful, then operation is the only treatment of choice. The best technique is to divide the sternocleidomastoid muscle at its distal and proximal attachment by the open method. Post of the neck is kept in over a corrected position for the 6 months with torticollis harness. After 6 months of physiotherapy is started. Laryngocele. This is a narrow-necked air-containing diverticulum resulting from the herniation of the laryngeal mucosa. It may be located internal or external to the laryngeal skeleton. Internal laryngocele may displace and enlarge the false cord and may result in the hoarseness or the airway obstruction, whereas the external laryngocele passes through the thyrohyoid membrane and present as a swelling in the neck over the thyrohyoid membrane. Laryngocele are more common in the glass blowers and the wind instrument musicians. Clinical feature: more common in the trumpet players and the persons with a chronic cough. Smooth ovoid swelling becomes prominent when the patient is asked to blow or perform Valsalva. Swelling is boggy in feel and may be resonant on the percussion. Sometimes it will fill with a mucoid fluid and may become infected, known as a laryngopyocele. There may be hoarseness of voice. Swelling may move with the larynx as on swelling. Treatment: the excised through the transverse cervical incision. Sac is dissected from the surrounding tissue up to the point where it comes out through the thyroid membrane. The neck of the swelling is ligated and divided and whole sac is removed. Membrane is repaired by the invaginating the stump of the neck. Now the pharyngeal pouch. Such a diverticulum arises as a protrusion herniation of the mucosa of the pharynx through the spot in the posterior pharyngeal wall known as the Killian's diacians. This weak area lies between the thyropharyngeus and the cricopharyngeus of the inferior constrictor muscles. Clinical features: suffers are the old age individuals, common in men, 2:1 is the ratio. There are 3 stages. Stage 1, the stage of the initial budding and the symptomless. There is a small diverticulum at the posterior aspect of the pharynx which has not touched the vertebral column. Complaint of the foreign body sensation: throat. Stage 2, the diverticulum is large, more globular and still lies in the posterior midline. Touches the vertebral column. Main symptom is a regurgitation of the undigested food material at different times. Such regurgitation may awaken the patient from sleep with a sense of suffocation and violent coughing. Occasionally lung abscess may develop due to the regurgitation of food into the air passages. The diverticulum becomes bigger in size and pushes the left side of the vertebral column. Fundus: the diverticulum becomes bigger in size in the stage 3 and it pushes to the left side of the vertebral column. The fundus of the pouch becomes dependent and lies in the posterior triangle of the neck. Mouth of the pouch opens horizontally upwards. Symptoms of the second stage persist. In 1/3 cases, swelling becomes visible in the neck and become larger and the patient drinks. Dysphagia is the main symptom of this stage. The gurgling sound may be heard in the neck as the patient swallows. Patient appear cachectic. Swelling lies in the posterior triangle of neck, posterior to the sternocleidomastoid and then anterior to the trapezius. Usually globular. Surface is smooth and edges is indistinct. Consistency is soft and cystic can be reduced initially. Fluctuation test is positive, transformation is negative. Barium swallow is the investigation of choice. Treatment is a stage 2 and 3 requires surgical excision. Endoscopy is the first performed. To pack the pouch with a ribbon gauge, to pass nasogastric tube into the esophagus to determine the position of the sac. Excision or diverticulum with the concomitant cervical esophagomyotomy. Cricopharyngeal myotomy is performed after the isolated diverticulum. Now the ranula. It is a transverse cyst on the floor of the mouth on one side or the other. It is considered to be the mucus retention cyst arising from the gland of the Blandin and the Nun, situated in the floor of the mouth. This cyst is usually unilateral. Pathology: cyst is lined by the columnar of the cuboidal epithelium. Cyst contains clear ropey fluid or a jelly-like fluid. Typical position of swelling is in the floor of the mouth, below the tongue, on the side of the frenulum. It is slightly bluish or greyish in color. Swelling is neither warm nor tender. Swelling is soft and firm depending upon the tension of the fluid inside. Both fluctuation and transformation test is positive. Types: simple ranula when situated only in the floor of the mouth without any cervical prolongation, and plunging ranula when the interbuccal ranula has a cervical prolongation. Cyst is considered to be derived from the cervical sinus. Such prolongation comes down along the posterior border of the mylohyoid muscle and appears in the submandibular region. Bidigital palpation should be done if sense of fluctuation is felt both sides. It is plunging ranula. The treatment: complete excision is the ideal treatment, partial excision with the marsupialization. The primary tumors: the thyroid mass, lymphoma, the salivary tumors, lipoma, carotid body, and the glomus tumors, and the neurogenic tumors. Well, thyroid masses. The leading cause of anterior neck masses. Children most common the neoplastic condition, male predominance, higher incidence of malignancy, adult female predominance mostly benign. Now the lymphoma, more common in children and young adults. Up to 80% of children with Hodgkin's have a neck mass. Sign and symptoms: lateral neck mass only, discrete, rubbery, non-tender, fever, lymphadenitis, splenomegaly, diffuse adenopathy. Lymphoma, FNAC first line diagnostic test. It is a history of lymphoma, open biopsy. Full workup, CT scan of the chest, abdomen, head and neck, bone marrow biopsy. This is a patient showing lymphoma. Now comes the salivary gland tumors. The enlarging masses anterior inferior to the ear or at the mandible angle is suspected. Benign, asymptomatic except for mass. Malignant, rapid growth, skin fixation, cranial nerve palsies. Now the carotid body tumor, rare in children, male equal to female, around 40 to 60 years. Versatile, painless, compressible, non-tender, round mass, mobile, medial, lateral, not superior, inferior. Clinical diagnosis confirmed by the angiogram or the CT. Treatment is the irradiation or close observation in the elderly. Surgical excision is a small tumor in young patients. Lipoma is a soft, ill-defined mass, usually greater than 35 years of age. Asymptomatic, clinical diagnosis confirmed with excision. This is a lipoma. A neurogenic tumor arises from the neural crest derivatives. Include a schwannoma, neurofibroma, malignant peripheral nerve shed tumors. Schwannoma most common in head and neck. Schwannoma 25 to 45% in the neck when extracranial. Most commonly between the 20 to 50 years, usually mid-neck in the post-thyroid compartment. Sign and symptom: medial tonsillar displacement, hoarseness due to vagus nerve, and Horner syndrome due to sympathetic chain. Lymphadenopathy equivocal or suspicious. FNAC in the pediatric nodal mass requires the open excisional biopsy to rule out the malignant of the granulomatous disease. Now the granulomatous lymphadenitis, infected develop over the week to months, minimal systemic complaints or findings. Common etiologies are TB, atypical TB, cat-scratch fever, actinomycosis, sarcoidosis, firm relatively fixed node with the injection of skin. With infection of skin, Now granulomatous lymphadenitis It is basically typical Mycobacterium tuberculosis, more common in adults. Posterior triangle nodes, usually response to the anti-tubercular medication, may require the excisional biopsy for further workup. Atypical Mycobacterium tuberculosis, pediatric age group, anterior triangle nodes, brownish skin induration and pain, usually responds to complete surgical incision and curettage. Now the cat scratch fever, Bartonella, pediatric group, preauricular and the submandibular nodes, and spontaneous resolution with or without antibiotics. Thank you.